Good evening. Good evening to one and all. I'm Dr. Sanjay Chaudhary from the Medical Affairs team of Sun Pharma. It gives me an immense pleasure to extend you all a very warm welcome on behalf of Sun Pharma for this today's medical webinar, Triggers of Asthma and Management, which is part of the Sankalp initiative. Before we start, let me give a short overview about the Sankalp initiative. Sankalp initiative by Sun Pharma has been created for handling lifestyle diseases like hypertension, diabetes, asthma, and GI disorders. So the word Sankalp comes from the Hindi word Sankalp, which means pledge for patient care. Promise of Sankalp program will helps you to be the first, but also the best in dealing with patients with lifestyle disorders. Through the Sankalp initiative, we aim to partner with doctors in the endeavor to offer quality healthcare. As part of the Sankalp initiative, we'll be regularly updating on global accredited CME modules, Indian and global therapy expert videos, recent articles from the best scientific journals, interactive webinars, etc. via calls, emails, SMSs, and WhatsApp, which will help manage patients better. So as promised, today we bring our third webinar of the Sankalp initiative, and today's therapy area is related to the respiratory therapy. And the topic for today's session is triggers of asthma and management. And I'm very much fortunate to introduce our guest speaker, Dr. Jagdish Chandra Suri sir, who is a renowned respiratory therapy care expert with extensive experience in the field of asthma. So before I start the session, let me introduce our speaker for today, Dr. Jagdish Chandra Suri sir. Sir is a director and head of department, Pulmonology, Critical Care and Sleep Medicine at the Fortis. Also, Rajendra Hospital, Vasant Kunj, New Delhi. Sir is a member of the National Expert Committee on COVID-19, Ministry of Health, Government of India. Sir has played multiple contributions in the medical programs of Government of India. Sir has been a part of multiple national and international professional societies like National College of Chest Physicians. Sir has been the founder, president, and chairman of the Indian Sleep Disorder Association. And sir is also the vice president of Asian Society of Sleep Medicine. Sir has more than 100 publications in national and international journals. Dr. Suri sir has also been the guest lecturer at multiple national and international forums. Without taking much time, now I hand over the session to Dr. C Suri sir to take it forward. Over to you, sir.
Good evening, everyone. Thank you, Dr. Sanjay Chaudhary, for the kind introduction. And at the outset, I would like to thank for this invitation today on a very important initiative that is Sankalp, which is a flagship program of education by Sun Pharmaceutical. I am really thankful to the team, Sun Pharma, Lakshman, and Chetna, and Dr. Sanjay Chaudhary. Today, as Dr. Sanjay Chaudhary has mentioned, we'll be talking about asthma. And not only we'll be talking about what asthma is, the triggers, as the title indicates, what are the important causes, triggers, and then we'll talk a little bit about the pathophysiology, which will make the foundation for the management of the disease. But before that, I would like to mention why we should be talking about asthma with the general practitioner. So as I am going to talk about the burden of the disease, the importance of this condition, you will realize that you people have to play a major role in the management of asthma because of the sheer burden of the disease, and taking into account the number of chest physicians, you will realize that with so much of burden, the chest physician will not be able to manage all the cases. So it's important for the general physicians to understand its pathophysiology, how to diagnose this condition, and how to manage this. So let me share my screen, and then we'll go about the topic, So as you all know that I have been part of Safdarjung Hospital, Bardhaman Mahavir Medical College and Safdarjung Hospital for the last 34 years before I joined Fortis Hospital. So let's talk about asthma. As you all know, that asthma is a heterogeneous disease which is usually characterized by chronic airway inflammation. So this is a disease of airway inflammation. We'll talk about this inflammation little in detail after some time. And the important symptoms with which the asthma expresses itself outward is in the form of wheeze, shortness of breath, chest tightness, and cough. So these are the four very important symptoms. That is shortness of breath, wheeze, chest tightness, and cough. And these symptoms vary over time and in intensity. So that means from a short period of time, you will see a significant variation in their intensity of these symptoms. And this is characterized by variable expiratory airflow limitation. So what exactly it means, I will be talking about this. So that's about the definition. And as I was mentioning to you that why this topic is important for the general practitioner. So this study, a very important study, tells you the prevalence of different symptoms in Indian population. That means if a patient from a community visits his general physician, so this is the distribution of symptoms, with which he or she goes to the local general practitioner. And you can see here that 51% of the total symptoms with which a patient goes to the general practitioner actually are the respiratory symptoms. So the respiratory symptoms are the most important symptoms with which patient visits his general practitioner. And amongst the list of diseases, if you see again a general practitioner sees, then you can see the most common diseases reported by physician in India are hypertension, asthma, and COPD. So you can see about 14.5% of the total patients are with hypertension, and then you can see the upper obstructive airway disease constitute 14. So this constitute, I think, significant number of cases a general practitioner sees on day-to-day basis. So if you look into the overall prevalence, then you can see that the global asthma prevalence in this, you can see that approximately 300 million people worldwide have asthma at the moment, and it is estimated that there may be an additional 100 million persons with asthma by 2025. This means it is not only that the asthma is highly prevalent, but its prevalence is going to increase in future due to various lifestyle factors we'll be talking. If you look into the Indian scenario, about 30 million asthmatics are there in India, and 10%, this constitute about 10% of the total worldwide burden for this thing. And this is again the prevalence of childhood asthma. Here, if you can see in the prevalence of childhood asthma, there has been number of studies which have been conducted in various parts of the country. As you can see, the name of the cities in which these studies have been conducted, and there is a lot of variability in the prevalence. As you can see in Kottayam, Kerala, Bangalore, you can see 15%, 11%. And then, so it all depends on what type of definition we have used, and whether these studies are questionnaire based or whether lung function tests have been done or not. And that's why we can see that there is a lot of variation in the prevalence of childhood asthma in our country. But I think overall, if you take all India figure here, then it constitutes about 6%. So anything between 5 to 10%, I would say, would be the prevalence of childhood asthma in India.
Sir, you can click on the slide.
Yeah, the slide was not moving. So out of this, you can see the red bar indicates severe asthma. So this is the prevalence out of this. So even severe asthma constitute a significant percentage of this thing. Now, again, this is another figure for the most common reasons for children visiting a pediatrician in India. Again, you can see that the respiratory symptoms constitute about 66% of total symptoms with which the children visit their pediatrician. So this is again indicating that this is a very important disease for the GP to understand, and the overall prevalence in the study, that is this Posidon study, is in children is about 11.6%.
Sir, actually, sir, your slides are not moving. So we are still on the slide. Approximately 300 million people worldwide currently have asthma.
Why? It's not moving?
No, sir. So if you can just exit from the full screen and put on full screen again, that would be helpful, sir. You can exit from the full screen, sir, and go to the slide which you're presently discussing, and then you can click on the full screen.
Actually, this the top bar that comes in between my slides, so it creates little problem.
Yes, sir. So there is one minimizing button, sir.
The initial, where was the slide? These slides I could show or not?
So we completed till 300 million population, sir. Approximately 300.
So here again, I can just say that if you look into the most common symptoms for which a patient visits a doctor in India, you can see that 51% of the patients have respiratory symptoms. And again, the prevalence of diseases reported by primary care physicians across India, again, you can see here there are three most important diseases are hypertension, asthma, and COPD. And that's the reason, a general practitioner should know about asthma diagnosis, asthma pathophysiology, and basic principles of asthma management. The global prevalence, if you see, then about you will see that there are about 30 million asthmatics in India, and this constitute about 10% of the world burden. As you can see here. I think there is some problem. The slides are not moving. Why the slides are not moving?
So just click on your slide and then try to change it.
Yeah. So this is what I mentioned, that about the prevalence of asthma in our country. It shows a wide variation in the prevalence because of the different criteria used for the diagnosis, and also whether it was questionnaire based or pulmonary function tests were used or not. And this you can see the prevalence of severe asthma. So we'll be talking about what the severe asthma is, which actually does not respond to the standard doses of inhaled corticosteroids. The another study again, which has been done for childhood asthma, and you can see again the children when they visit to their pediatrician, the most common symptom with which these children visit are the respiratory symptom, which constitute 66%. And out of this, in this Posidion study, the prevalence of asthma is about 11%. And the prevalence of asthma based on symptoms, as you can see, is 30.4%. So it's very important that when we are looking into the prevalence figure, we must look into the diagnostic criteria, whether they have been subjective questionnaire based or they are objective criteria. Now let us, now after knowing the burden of the disease and the reason for today's talk for the general practitioner, now let us talk about the common risk factors or what causes asthma. And then you will see that asthma is a heterogeneous disease in terms of its inflammation, as we mentioned in the definition. A large number of factors are responsible for the development of asthma, and they can vary from, as you can see here, are the genetic factor, where the family history is very strong. As you can see that there is a 7 times increase in risk of developing asthma if somebody has asthma in the family. And then there are the environmental factors. So asthma is basically a combination of genetic factors and the environmental factor. And among the environmental factors, there are allergic factors here, like you can see the home wall dampness, then the various pollens and this thing. And then, of course, smokers at home, snoring at night, preterm delivery, absence of kitchen, mixed feeds, so cesarean. These are basically factors which we have seen in children. These are the risk factors seen in children here in a study which was conducted in 4,000 children. So as I was mentioning to you, that asthma is basically a disease with a strong genetic predisposition. So in order to develop asthma, one has to have a genetic predisposition, and then there are these environmental factors. So if there is a family history of asthma, the risk of the individual having asthma increases by 7.24 times. And that's why the asthma is one of the most heritable diseases, this thing. And what is the genetic predisposition? We know is somebody who has genetic predisposition to develop asthma also have what is called atopy. Now, what is this atopy? Atopy is a genetic predisposition to form large amount of IgE antibodies to common allergens. So when we make a lot of IgE antibodies to common allergens, then we become vulnerable to develop 4 types of condition. And these includes asthma, allergic rhinitis, eczema, and migraine. So this 4 conditions constitute atopy, and that is basically genetically transferable for this thing. So that's why it is very important, and these conditions are not mutually exclusive. A patient can have childhood eczema and later on may develop allergic rhinitis and subsequently asthma, or they may have simultaneously eczema, asthma, and allergic rhinitis. So this is what we call it genetic asthma, allergic asthma, early childhood asthma. Most of these conditions usually start in the early childhood. The environmental factors, as I mentioned to you, in children particularly, when the disease starts early, cesarean delivery, increases the risk by 4 times. So that's what you can see. So after genetic factors, cesarean section is the second biggest risk factor for the asthma. So baby born by cesarean section have 4-fold higher risk of developing asthma in their later life, this thing. Then the another important factor is the preterm delivery. The preterm delivery leads to low birth weight, and you can see here, the birth weight less than 1,500 grams, 1,500 to 2,500, and more than 2,500. Then you can see the odd ratio of developing asthma becomes higher and higher, as the birth weight becomes lesser and lesser at the time of the birth in these patients. Then smoking history. This is a very important factor, because these are all things which will be used for prevention of asthma. And so you can see here, air pollution in womb. Then if you can see here, if the grandmother smoked during pregnancy, the mother smoked during pregnancy, then the risk of asthma becomes, if the mother smoked, it is 1.8 times. If both mother and the grandmother smoked during their pregnancy, the risk goes to 2.6. So this has a important implication for these things. Then next very important triggers, amongst the trigger will be the air pollution. The air pollution can be indoor air pollution and the outdoor air pollutions. The indoor air pollution, you see, basically, particularly when there is absence of separate kitchens. And what you can see here, basically every day in these homes, where there are no separate kitchens, it's part of the house, and if it is not adequately ventilated, then most of the family members, particularly the lady who is cooking the food and the children, there is about 2 to 6 hours of exposure to these indoor air pollution on the daily basis. So this may lead to the inhalation of such a large amount of air, which is highly polluted with various chemical components. And not only the mother, but the children becomes much more vulnerable as they develop recurrent respiratory tract infections, poor lung growth, and the risk of asthma becomes very, very high in these cases. So the other types of indoor pollution you can see, which we commonly use, dhoop, incense burning, which is obtained from the tree bark. This also causes significant air pollution. Then we look into the outdoor air pollution, the truck traffic density and the childhood asthma, particularly those people who are living close to the heavy traffic area on the main roads. If the houses are there, there is a significant increase in the risk of developing this thing. So living in homes close to the busy roads, that is less than 50 meters, is significantly associated with the increased asthma risk in children. So you can see here, there is a wide, variety of risk factors or triggers here. You can see the vehicular air pollution and asthma prevalence. And then this another study here, you can see that the risk of asthma increases with the increasing degree of air pollution. So low traffic here, the risk is 11%, heavy traffic 19%, and heavy traffic plus low socioeconomic status combined. So you can see that the risk is significantly increased. So this all indicates, the living conditions, the environmental factors, and the exposure to this thing. Then the outdoor factors includes our diesel exhaust particles, which increase allergen-specific IgE levels by up to 50 folds. So when you inhale normal allergens and triggers, and if you also inhale diesel exhaust particles, this actually makes these pollens and the other allergens much more potent. So the pollens become more allergenic when these trees grows in an urban environment. So it's a combination of organic and inorganic pollution which result into these things. And of course, inorganic, you see these all types of chemical gases and this thing which leads to this thing. And then in children, particularly the food, the mixed feeds, we all know that the feeding is the best thing the child can get in the first 6 months, and it is associated with the decreased infections and the risk of developing asthma. So mixed feeds they constitute about 10% of asthma in children. So asthma, obesity, and consumption of fast foods. So if you can see here, again, the odds of severe asthma, with these types of food is significantly higher. So obesity is a significant risk factor for asthma. So those people who are obese, particularly if they are children or adults, they become vulnerable to develop asthma. The reason is that when a person is obese, his chest wall becomes thick, the lung volumes become smaller. When the lungs volume becomes smaller, the breathing tubes, the bronchi, and they also become smaller. So their lumen becomes narrow. So they overall have a narrower airways, and once they develop any inflammation in that, the airway narrowing becomes much more significant in this. So the fast food, there's an 3 times increased risk of developing. The obesity is also associated with asthma. Consumption of fruits for more than 3 times a week was associated with an up to 14% reduced risk of severe asthma. So the food also plays an important role in the development of asthma in these things. So dietary and lifestyle changes which are associated with the childhood asthma, as you can see here, there's a high intake of fats and simple sugars will increase asthma. Increase intakes of fruits and vegetables and increased physical exercise will definitely decrease the prevalence of asthma. So these are the important thing. And then, of course, in the indoor pollution, you can see the home wall dampness. The home wall dampness is associated with the growth of the various fungi. So this is what you can see, the damp walls at home, the fungus, and the childhood asthma. Again, you can see that the damp walls at home increase the indoor fungus level by up to 3 to 5 times and worsen the asthma. And not only it increases the prevalence of asthma, but it also worsens the control of asthma because of the continuous exposure to the antigen throughout the year. Then there are certain occupations which are associated with asthma. And what are these occupations? These are welding, woodwork, painting, soldering, bakery workers, and hairdressers. So these are the type of occupations where when the people are working are at a higher risk of developing asthma for this thing. So in India, if you look into the patient-reported triggers, then you can see that the majority of the patients report about dust, pollution, fumes, ice drinks. So like that, changes in the weather, chemicals, tobacco smoke, food and drinks, perfume, so exercise, stress, pollens, animal denders. So all these are now considered to be the triggers for asthma. So initially, the triggers which are coming from the organic source. Organic source means those coming from, say, trees, pollens, animal dander, house dust mite. These organic, they are considered to be allergens because they contain proteins. They are coming from the living source. They were considered allergens. And those who are coming from non-living source like dust, fumes, change in temperature, weather, stress, they were considered as triggers. But now we know that all of them are actually associated with not only the development of asthma, but also in the worsening of asthma. So these are the, in total, if I have to put it together, the triggers here. So these are the various triggers. You can see pets, exercise, pollens, chemicals, fungus, spores, dust, and this thing. So what does this indicate? That means the asthma can be caused by wide variety of triggers. So when a person who is genetically predisposed, when gets exposed to these triggers, then this person is going to develop a kind of immune response or an immune inflammation, which is going to be very heterogeneous, because when the triggers are heterogeneous, then the inflammation is also like to be heterogeneous. And we know that there has been a significant evolution or improvement in our understanding of pathophysiology of asthma in the last 4 decades. In 1970s, we used to think that asthma is simply bronchospasm, and that is why bronchodilator was the treatment of choice. And subsequently, we realized that it is both bronchospasm and inflammation. And then not only it is bronchospasm, inflammation, but then if this inflammation is not treated adequately and effectively early, then it can lead to fibrotic changes. It can lead to remodeling and irreversible airflow obstruction. So that's the understanding which we have, and we haven't. Not only this is inflammation, we have also come to know about various types of inflammatory cells. In the 1980s, we only thought that it is the mast cells which are important, and that is why you must have seen in the 80s it was the mast cell stabilizers, like those drugs which were used to suppress the release of mast cell mediators. So those were the drugs which were used to treat patients with asthma. Subsequently, we knew that the mast cells release various granules which have histamine, which has various pro-inflammatory cytokines, particularly IL-5, prostaglandins, and leukotrienes. So all of them would lead to bronchoconstriction, mucus secretion, and mucosal edema, and this thing. So, and then ultimately this attracts eosinophils and activate eosinophils. So this was the initial thinking, but then subsequently in 1990s we realized that eosinophil are the most important cells, and actually even though initially it is the mast cells, but ultimately it is the recruitment and activation of the eosinophil which results into this complex inflammation. And this was very elegantly shown that as the eosinophil count increased in the airways, the severity of the disease also increased, from control group to intermittent to mild to moderate to severe asthma. So it clearly indicates that eosinophils are important cells. And then subsequently T cells came into picture, and that Th2 and non-Th2 mechanisms, and it was found that it is the T cells, which when they get activated on exposure to the allergen, they release various cytokines like IL-4, IL-5, and IL-13. And ultimately, the IL-5, which activates eosinophils, IL-4 actually goes to the IgE pathways, which cause increased response to these things, and IL-13 actually cause epithelial activation and fibrogenic response. So that's why we had basically remodeling pathway through T cell through IL-13. It leads to airway remodeling through IL-5. It attracts and activates eosinophils, and then IL-14 IgE mechanism for this. So we have the mast cells and airway inflammation. We have talked about the eosinophils for this thing, but now we know that it is the Th2 cells, which are the most important cell, which are actually which is the orchestrator of the whole inflammation. And according to the type of cytokines it will release, you will have the type of inflammation. So the inflammation, whether you will have inflammation, airway remodeling, eosinophil activation, or IgE pathways, it would depend on which pathway is stimulated. And when you are using anti-leukotriene drugs as the only drug, then you will be only taking care of only one pathway. So that's why anti-leukotrienes alone should never be given to patients for the treatment of asthma. It is the combination. It is actually should be used as a add-on drug for this thing. And the steroids, which is now we use as the inhaled steroid, constitute the comprehensive anti-inflammatory agent for the treatment of this thing. So this slide summarizes all the triggers. We see we have the allergens here. We talked about those coming from the natural sources like pollens, like house dust mite, animal dander. And then we have these environmental pollutants, or viral infections, microbes, glycolipids, pollutants, and this thing. So all of them, can actually stimulate various pathways. The one pathway is from the Th2 pathway. Th2, as I mentioned to you, the lymphocytes, and through that you can have either through mast cells and through IgE pathway or through eosinophil pathways. So you can have these kinds of inflammation. So this pathway is called allergic inflammation, where you have allergic eosinophilic asthma. And then through this pathway, when you are these pollutants and microbes and this thing here, you can again have recruitment of eosinophils. So this is called non-allergic eosinophilic asthma. And then you can have other pathways, through Th17 cells, which leads to remodeling or neutrophilic type of asthma. So now you can understand that asthma inflammation is very heterogeneous, and steroids are only helpful in treating this type of allergic asthma or even non-allergic eosinophilic asthma. The steroid may not be very good in treating this neutrophilic asthma and this the asthma caused through the Th17 cell pathways. So any patient with asthma actually can have a combination of these inflammation, and that's what we mentioned here is that the Th2 inflammation, which is the allergic inflammation, and non-Th2 is the non-allergic inflammation. So in any patient, actually it is a combination of these two. If the patient has a predominantly Th2 allergic inflammation, these patients are going to respond to inhaled corticosteroid very well. And on the other hand, if the patient have non-Th2 type of this thing, then they are less likely to talk to the likely to respond to the inhaled corticosteroid. So that's, I think, the basic the principle I think one has to understand when we say treating for this thing. So asthma is a heterogeneous disease, usually characterized by chronic airway inflammation, and the symptoms are basically wheeze, shortness of breath, chest tightness, and cough. So the diagnosis of asthma is clinical. We are not using any inflammatory markers. We are not doing any biopsy of the airway to diagnose asthma, because even if you take a biopsy, the inflammation is going to be very heterogeneous and diverse. So the diagnosis, so that's why asthma is considered a syndrome. So asthma is diagnosed on clinical picture, and it is very important to make a correct diagnosis of asthma on the basis of symptoms. So if you see, but symptoms alone may be misleading. So as I mentioned to you, the diagnosis of asthma requires both. First is the history of symptoms like wheeze, shortness of breath, chest tightness, and cough, and also it requires pulmonary function test. That means the demonstration of airflow obstruction, and the reversibility of that airflow obstruction to differentiate it from the COPD. So that's a very important. So the diagnosis is based on history and the clinical examination. And in the clinical examination, you find wheezing and crepitation on this thing. How accurate is the clinical examination alone? So if you use only clinical examination, that means only symptoms and the physical examination, then you will find that in 70% of the cases, the asthma will be underdiagnosed. And in about 38% of the cases, there will be overdiagnosis. So if you use only clinical picture, the symptoms, there is 70% underdiagnosis and 38% overdiagnosis on this thing. So that's why use of spirometry or peak flow meter, these two is essential for the accurate diagnosis. So you have to use a combination of clinical picture and the use of spirometry and the peak flow meter to make the diagnosis. And these are the symptoms, as I told you, the most important. So any patient with the background of wheeze, shortness of breath, chest tightness, and cough, which is dry and sometimes productive of sticky mucus, then these patients should, there are certain things in these symptoms which makes the asthma more likely. That is more than one type of symptom. That means the patient should have wheeze, shortness of breath, cough, and chest tightness. Chest tightness is because of the bronchospasm. And the most characteristic part of this symptom is that these symptoms are worse at night or early morning. So the sleep is very commonly disturbed, and that is why it is included as a part of control of asthma. And these symptoms vary over time and intensities. And the symptoms are triggered by viral infection, exercise, allergen exposure, changes in weather, laughter, emotion, stress. These are all the triggers here, or irritant exposures of these things. And if there is a chronic production of sputum, shortness of breath associated with dizziness, lightheadedness, peripheral tingling, chest pain, these are not usually the features of asthma for these things. So chronic symptoms, which are lasting over a period of months and years, which usually start from the childhood. If there is a history of allergic rhinitis and eczema as a part of atopy, there is a strong family history. And if there is the patients are totally asymptomatic in between, and usually the condition resolves sometimes on its own or with treatment. So that these are, features which are very highly suggestive of asthma. And for the diagnosis, so these symptoms features are not specific for asthma and may not be seen in all phenotypes of asthma. So the non-allergic asthma, you may not find, say, eczema, allergic rhinitis, and they may start in the later part of the life. So these are important things for these things. So you must also, exclude asthma mimics, or these are the comorbidities which are commonly associated with asthma. These are allergic rhinitis, which is a part of atopy. Gastroesophageal reflux syndrome is a very commonly associated with asthma exacerbation because of the reflux of acid into the upper airway. The cardiac failure, obesity may be present with symptoms and signs suggestive of asthma. So these are the common comorbidities, which should be looked into and taken into account while making a diagnosis. So what is the role of lung function tests? Basically, in the lung function, what we are trying to demonstrate is expiratory lung function, expiratory airflow obstruction. And this expiratory airflow obstruction is variable, means from morning to evening, there is a day-to-day variation in the airflow function. So that's why if you do multiple readings, you will show a wide variation in the resistance to airflow. So expiratory lung function will vary over time, and magnitude of variability is greater than that of the healthy subject. So even in a healthy subject, there is some variability of morning and evening airway function, but in these cases, it is significantly more. So the most important test which we use is the spirometry. So good quality spirometry is more reliable and informative than the peak flow meter test. So that should be done wherever it is available. And use of actual measure, you have to take, it is the FeV1 FVC ratio. That means the amount of air which is breathed out in the first second is very important. So it's the ratio of the total amount of air which is breathed out, which is the vital capacity, and the amount of that which is breathed out in the first second. That tells you about the airflow obstruction for this thing. So spirometry may be normal in some patient, but in symptomatic patient, those who have cough, sputum, wheezing, chest tightness, spirometry should always be abnormal. And if you have, in the presence of symptom, normal spirometry, you should think of alternative diagnosis. And what should be this ratio? Normally, this ratio changes with age. And if you want to take adults, then 70% of the air should be breathed out in the first second of the total vital capacity. In children, it is 90%. Adults below 40 years, it is 75%. And then elderly more than 65 years, it is 65% of this. This is what you will take as the ratio. So what when you suspect a patient with asthma, what you are going to do is you will do the spirometry and you will take their FeV1 FVC ratio. If the FeV1 FVC ratio is less than 70% in elderly, or less than 40 to 75%, then this is considered to be airflow obstruction. And then second thing, what is important for the diagnosis of asthma is that these patients are given bronchodilator. That means salbutamol, about 400 microgram with meter dose inhaler and spacer. And then up to 15 minutes, when there is a peak effect of this inhaler, you repeat the spirometry. And if you are able to show improvement in the FeV1 by more than 12% or 200 ml from the baseline in the first reading, then this is indicative of significant reversibility. So FeV1 reversibility of more than 500 ml and 15% is very strongly suggestive of asthma. Although we are taking 200 ml and 12% reversibility as suggestive, but if the improvement is more than 400 ml or 15%, then it is suggestive of diagnosis of asthma. If suppose the spirometry is not available, in that case, you can use a peak flow meter. And again, peak flow meter is a device where which should be used when the good quality spirometry is not available. And this meter is easily available. It is inexpensive. It is handy and easy to use. So what does this peak flow meter does? It measures the peak expiratory flow when the patient takes a deep breath and blows hard in the peak flow meter. So if the peak flow is reduced, it suggests airflow limitation. So again, how much reduction you want to expect from the patient's best value or from the predicted normal? It should be less than 80% of the predicted PEFR for that age and this thing. Or if the patient has been using peak flow earlier, then it should be 80%. Less than 80% of the patient's personal best, because patient personal best will always be more accurate measure to refer to than the general population figure for this thing. So not only this, that you show a decrease in the peak flow less than 80% of the predicted normal, but also after bronchodilator, if there is a more than 20% improvement in the peak flow value, it is suggestive of bronchodilator reversibility. So peak flow can be used for diagnosing airflow obstruction, but also indicating reversibility and making a diagnosis of asthma in patient with background this thing. And also a better approach is that you give the patient to measure their peak flow morning, evening for 1 to 2 weeks. And then you look into the variability, daily variability function, and you look into the morning and evening reading. In healthy individual, this variability will always be less than 10%, and in children less than 13%. So if you find that over a period of 1 week or 2 weeks, and if you look into the morning reading and evening reading, and if there is more than 10% variability, it is very strongly suggestive of a hyperexcitable airway, which is a strong feature of bronchial asthma for this thing. So that's how we make the diagnosis. And next, when we go to the management of asthma, so what are the goals of management of asthma? The goals of management is to improve the symptoms. Of course, the patient comes to you with symptoms of cough, chest tightness, wheezing, breathlessness. So you have to control these symptoms, and not only you have to control the daytime symptoms, but you also have to control the nighttime awakenings due to cough, due to chest tightness, due to this thing. And then you should also look into the comorbidities. As I mentioned, the common comorbidities which makes the asthma control difficult is allergic rhinitis, gastroesophageal reflux disease, obesity, depression, and we have depression and obesity, allergic rhinitis, gastroesophageal reflux disease. These are the common the comorbidities, and they should also be managed effectively. And then the lung function should improve. The patient's airflow obstruction should normalize. Then there should be structural recovery and functional recovery the functional status improve, and overall it leads to improvement in the quality of life. And this should be associated with the decreased exacerbations, decreased emergency visits, treatment-related adverse side effects, hospitalization, and the patient disease progression should be halted. What is this disease progression we talked about? That is airway remodeling, irreversible airflow obstruction, and this thing, and of course the mortality. So this should not lead to early death. So these are the usual goals of treatment, and so our goal should be our patients basically is symptom control and good quality of life. So patients should not have asthma attacks, no recurrent symptoms, no dietary restriction, no activity restriction, no loss of work or school attendance and this thing. So and no nighttime awakening. So these are the important goals of treatment in most of these cases. And the long-term goals are preventing asthma exacerbation, preventing fixed airflow obstruction, and and all these things should be achieved with the minimal side effects of medications like tremors, palpitations, and this thing. So these are the common side effects which we see for this thing. So what is the status of treatment? So if suppose you look into the control of asthma in patients of asthma who have been receiving this treatment, the standard treatment, and if you try to see the degree of control in them, you will find that there is a lot of difference between a gross difference between the patient perception of control versus what the GINA guidelines defined as the control. So there are definition by GINA guidelines and by the patient's own perception. So if you ask the patient how well is their disease control, then you will see that 29% of the patient will tell from their own perception they are well controlled, and then 60% will say somewhat controlled, and then 7% poorly controlled. But if you objectively assess these patients on the basis of GINA guidelines of control, then you will find that 40% of the patients are uncontrolled and 60% are only partly controlled. So 0% patients are well controlled in this thing. So this clearly indicates that the treatment of asthma in the population is far from satisfactory. So this data basically suggests that most of our patients of asthma are uncontrolled, and a majority of them do not know that they are uncontrolled. So because their own perception is also not there. So that is a very, very important thing. If the patient is uncontrolled and patient does not appreciate that his disease is uncontrolled, then he will not seek the treatment, and the disease may progress and develop, and the patient may develop long-term complication for this thing. So what are the important asthma components of asthma management? So first, it is very important to develop a patient-doctor partnership. That means where the doctor should be able to explain to the patient about what asthma is, what causes asthma, and what are the common triggers for this thing, how to diagnose, and then what are the important principles of management, what is the purpose of each drug which the patient has to this thing, And it is also important to identification and avoidance of triggers in each cases. And then once the patient comes to you for the first time, it is very important to assess the severity of the disease and the level of control, because many times patient may come to you when he is already taking treatment from some other place, and some kind of treatment the patient is taking. So it's important for you to find out what treatment the patient is getting, and what is the severity of symptom patient has, and what is the level of control. And that will help you in deciding that what more you have to do for the management of these patients. And then you have to prescribe the medicine on the basis of this medicine, and prescribing appropriate inhaler devices and training the patient on the correct technique, because it's very, very important that it is when you prescribe inhalers to these patients, or these drugs, inhaled drugs to these patients, the important thing is to ensure that they take this medicine and use these devices correctly, so that the adequate amount of drug goes into their lungs and they get the maximum benefit. And once you have started the treatment, you need to regularly monitor to check for adherence and level of control. The use of asthma control test, peak flow monitoring, and this thing, and then also regularly checking the technique of usage of these devices. And then once the patient develops a good control, then you step down the treatment, or if the patient has not achieved the good control, then you may have to step up the treatment. And then giving the patient a kind of written asthma action plan. That means on long-term basis, the patient is given a plan that in case their symptoms deteriorates, in case when their asthma control test reading shows a decline in their asthma control, or their peak flow readings are falling, then what treatment he has to take. Those the treatment written asthma action plan has to be given to this patient, and also addressing the comorbid condition, as I have mentioned, to all these things. So the first important thing is the triggers, which I've already talked about. Avoiding quit smoking, making home a smoke-free zone, encouraging household members to quit smoking. Dust mites, again, washing your beddings weekly, drying it completely, and vacuum carpet cleaning. All these things. Use of air filters, the use of vacuum cleaners, wear of these the air purifiers with HEPA filters. So all these things, control of humidities, these are important things. Outdoor air pollutions, of course, is important. So these asthmatic patients, when they are going out, they can pay attention to the air quality forecasts on various channels, radio, TV, or internet, and then they can plan their activities accordingly, what time of the day they have to go out for this thing. The pest control is very important, the cockroaches, the house, the other, particularly the cockroaches and the other pests, which are often found in the food grains and this thing. So their use of pesticides and other, taking care of their storage spaces properly can take care of these things. The pets also, again, particularly the animal dander, the hair or the furry pets, they can trigger an asthma attack if a person is allergic to them. So again, decreasing exposure to keeping pets out of bedroom, use of air cleaner with HEPA filters, and using allergen-proof mattresses and pillow covers. So these are the important methods, and control of molds, particularly in the areas, where there is a lot of leaks, water leaks are there. Fixing those areas are important. The various viral infections are also associated, particularly the flu and the respiratory syncytial virus. So I think the annual intake of these vaccines can help these patients, and the other triggers can also be taken care of. We have talked about the allergens, pollens, particularly in the pollen season, the windows and the doors can be kept closed, and the person should not be going out for a long period of time. So these are important things. Avoiding physical exercise, bad weather, all these things are important in the control of these things. Regarding the treatment, pharmacotherapy, you all know pharmacotherapy is just one component of the overall holistic management of the patients with asthma. The current therapy is limited to inhalation therapy because there is very little scope for using oral medication except in exacerbation, because these inhaled medicines are much more effective. They are quick in acting. You may have to take much less dose, and they will produce less side effects for this thing, And what we have to prescribe, these are the most of the devices which are available here. We have basically two types. One is what you call the meter dose inhalers, which are there as sprays, and second is the dry powder preparations, which are available as a single dose or multi-dose formulations. We have this. So there are two types of devices available. Both are equally effective if they are properly used. So that's very little to choose between them. And what basic medicine we are using is, we normally we have known, that the asthma is basically, if you look into the pathophysiology, it is characterized by inflammation. So what we mean by inflammation is that if you look into the airway of an asthmatic, you can see that it is swollen. So there is an airway inflammation. The mucosa, submucosa is swollen, and there is a spasm of the muscles, and there are secretions in the lumen. So their airway lumens are narrow. So that is what you see normally in an asthmatic with inflamed air. And when they are exposed to a trigger, there is an acute attack. What happens in acute attack is that the muscles which are around these airway, they undergo spasm. And with this spasm, there is an acute narrowing of the airway. So when you are using drugs to treat patients with asthma, you have to use drugs to control this inflammation, number one. And number two, when patient comes with acute asthma, with acute attack, you have to use bronchodilator muscles, the reliever drugs, which will relieve the spasm caused by these muscles outside these airways. So these are the two these things. So you see the bronchoconstriction and you see the airway inflammation. The control of inflammation and adequate bronchodilation is the hallmark of pharmacotherapy of asthma. So that is the most important thing which you have to see here. And what are these the drugs which are used to control this inflammation? The inhaled corticosteroids are the drugs of choice for inflammation, and short-acting bronchodilators are the drugs of choice for relieving bronchospasm, particularly during the acute attack. Otherwise, you can use long-acting bronchodilators and inhaled corticosteroid in combination in treating the patient on long-term basis for this thing. So what are the first-line drug here? You can see the controllers or the anti-inflammatory drugs. The anti-inflammatory drugs are the inhaled corticosteroids. Here you can see these are in the order of preference. Here you can see they are most effective and safe anti-inflammatory medication. They are the first line, and almost all asthmatics need to be given ICS. As I mentioned to you, use of other drugs like Montelukast, but they have they are effective against one pathway of the inflammation, and they should always be used as an add-on drug. So inhaled corticosteroid is the most comprehensive anti-inflammatory drug. It should be used, and inhaled corticosteroid alone, if they are not effective, then you have to use them along with long-acting beta-2 agonist, which also relieve the bronchospasm and act in synergistically with inhaled corticosteroid to produce the anti-inflammatory drug for this thing. And then, of course, the anti-leukotrienes, they are always used as an add-on therapy, as just mentioned, and are useful in patients who have simultaneously allergic rhinitis, post-viral Vs, or exercise-induced asthma. So exercise-induced asthma. So these patients, you can use anti-leukotriene drugs, and the other anti-inflammatory drugs are the long-acting muscarinic agents, and this is the newer emerging role, and they are again add-on drugs. They should never be used as the first-line drug for this thing. And lastly, the oral theophylline, and they are also is the last choice as a part of the anti-inflammatory drugs. So when inhaled corticosteroids are not able to control inflammation, then you can add the other anti-inflammatory drugs sequentially to make the treatment for this thing. And we can see that these inhaled drugs are associated with significant decrease in number of various inflammatory cells here, and these drugs are quite safe, and there is no absolute contraindication. But long-term use of steroids, particularly in a higher dose, may have some systemic and local side effects, and so therefore the patient should be monitored for this thing. But usually low to intermediate doses of these drugs are not usually associated. And once you give high dose inhaled corticosteroid over long period of time, then the common side effects which you should look for are the suppression of HPA axis, osteoporosis, growth retardation. So these are the particularly in children, you have to look for this. And we have seen that once the children grow, there is a catch-up growth. Once their asthma improves, the dose of inhaled steroid is reduced. Usually we see a catch-up growth in most of these cases. And then there are local side effects in the form of oropharyngeal candidiasis, dysphonia, and cold phlegm effects for this thing. The most common available drugs are the budesonide and fluticasone, and they can be usually combined with long-acting beta-2 agonist. The other inhaled corticosteroids are also available, but these are, I think, these two are the most commonly used, and these are the doses: the low dose, the medium dose, and the high dose. In this dose, they need to be started and gradually increased for this thing. So there is usually a debate when the patient is not responding to low to medium dose, whether we should go to the high dose or we should add another anti-inflammatory drugs like montelukast, or we use theophylline group of drugs. So that's what has been most widely mentioned. So these are the another drugs, and recently we have these biological drugs, with what we call the targeted therapies, which are used against particular cytokines like IL-5, IgE. So these are the newer drugs which are particularly used in patients with severe asthma for this thing. So I think I will just give you this last slide of the treatment of asthma. When we started treatment, we divided asthma into intermittent asthma, mild persistent, moderate persistent to severe persistent. That means on the basis of the severity of the symptoms, we used to divide these patients into mild, moderate, and severe. But now what we have seen that the mild, moderate, and severe disease should be defined, the severity should be defined on the basis of response to treatment. Because a patient may come to you with the severe asthma, but may actually respond to very low doses of steroids. So then in that case, this becomes a mild asthma. So we should take into account the patient's responsiveness to therapy. For example, a patient may first be seen in an acute exacerbation, yet he requires a very low dose of ICS as a daily maintenance therapy. So now we say a patient to be mild when he requires very low dose of steroid and becomes controlled, to severe patient, which a patient with very high doses of inhaled steroid and still is not fully controlled. That is the patient which is considered to be a severe disease. So the severity of a disease from mild, moderate to severe depends upon the response to therapy for this thing. And the guidelines which are being given by the Global Initiative of Asthma is that when you start treatment with your patient, so you look into initially you look into the symptoms, whether the symptoms are milder, that means they are less than 4 to 5 days a week, or whether symptoms are on the most of the days, waking with the patient or with the walking or every day and then during the night, or daily symptoms, or waking with asthma once a week or more, and when the lung functions are low. So depending upon the severity of symptoms, their presence during every day, throughout the day, the sleep is disturbed, or they are coming intermittently, on the basis of that, the guidelines are to start the treatment with the low dose steroid, intermediate dose, as we have mentioned, or a higher dose. So Once we start the treatment on the basis of these symptoms, then these patients can be followed up, and they can be given in between if the symptoms are there. But most of these patients should be given a combination of controller and reliever. That means a combination of inhaled corticosteroids and long-acting beta-2 agonists. So this would lead to control of both inflammation and symptoms. And the same combination can also be used as a rescue inhaler. That means whenever the patient has symptoms, the patient should use the rescue inhaler as a combination rather than bronchodilator alone. So on the basis of this, the treatment is started, and then the patient should be assessed over a period of time. And once the asthma control, when you start this treatment, the patient should be evaluated on a monthly basis, and then you should look for the symptom control, the asthma control. So you assess for symptom control, check for their asthma control test, look for their peak flow readings, check for the inhaler technique, administer asthma control test. And then once you find that when the patient is adequately controlled, then you can consider step down of the treatment. You can reduce the dose of the inhaled corticosteroid. And if the patient is not fully controlled on whatever on the basis of which you have started the treatment, then you may have to step up the treatment for this thing. So asthma control test is the most important tool. Here, it's basically there are 5 simple questions, and there are 5 answers. And each question has 5 answers. And then on the basis of that 5 questions, the maximum score is 25. So if the patient score is more than 21, then it is considered to be well controlled. So this asthma control test is the most important tool, and the used to assess the control of this thing. And we can also use the peak flow monitoring to look for the airflow obstruction and the day-to-day variability for assessing the control of these tests. So this is how we should, I think, manage this patient and follow this patient. And our approach should be focused, and it should be basically a patient-centered approach, depending upon the patient's symptoms, patient severity of disease. And each patient is different because their triggers are different, their inflammation is different, and that is why their response is different. That's why one size does not fit all. So you should start controller therapy early. So it's very important to start with inhaled corticosteroid as early as possible, and then ensure that adherence to therapy is good. And then ultimately it is the good communication and developing a partnership, which is the key to successful treatment of these patients. So the success of asthma therapy is basically a good communication, a good partnership of the patient as well as the doctor. The doctor should be willing to teach the patient about the basic principles of management, and patient should comply by taking that treatment regularly, by monitoring his symptoms, his disease regularly, and then taking the various decisions, particularly following the asthma action plan, depending upon what the patient is supposed to do under different circumstances. So this is what I've just tried to give you an overview of what the asthma is, what is its clinical presentation, what are the different triggers, management principles, and how to follow up these cases. Thank you very much. I'm sorry we got a bit delayed because of the initial glitches. I'll be very happy to answer if there are any questions to that.
Yes, sir. So first of all, I would like to thank you for covering this topic completely and in a complete detail, sir. So although so many queries have been addressed, but just in case if we have missed something, we'll take up those queries, sir. The first query is, as you had discussed regarding the IgE levels in the management of asthma. So there is one query related to that. How do we manage high levels of IgE levels?
See, IgE is a marker of inflammation. As I said, that asthma inflammation is very heterogeneous. We have allergic asthma, we have non-allergic asthma. And in the allergic asthma, when the patient is exposed to organic allergens, like pollens, house dust mite, molds. So when these allergens, are picked up by the body through the epithelium of the airways, then the Th2 cell interact, and different pathways are activated. So one pathway is a basophil pathway, which causes release of large amount of IgE. The other pathway is IL-5 pathway, which causes eosinophilic inflammation. So those patients where this pathway is activated, they will have high amount of IgE. So these are the patients who will have early onset asthma. Their asthma is from childhood. They have allergic asthma. They have other atopic features like eczema, allergic rhinitis, and asthma. And IgE level simply indicate that he's an allergic patient, and they are allergic to common allergens. But the level of IgE does not correlate with severity of disease. So when you are treating a patient of asthma with inhaled corticosteroids, majority of patients, 80 to 90% of the patient will respond to low to moderate doses of inhaled corticosteroid. But if a patient on very high doses of inhaled corticosteroid, or may also require oral corticosteroid for the control of asthma, then this treatment can have long-term side effects like HPA axis suppression, on osteoporosis, the cataract, as I mentioned to you, growth retardation, those factors there. So in such cases, we try to give them biologicals so that we should be able to, we can reduce their inhaled corticosteroid and make them in the safer doses. So if the Ig levels are high, that indicates that we can give them a monoclonal antibody, the name of omalizumab. So omalizumab is the monoclonal antibody which is given to patients with high levels of IgE, and the dose of omalizumab is guided by patient's weight and the IgE levels. But overall, there is a poor correlation between the level of IgE and the severity of asthma, as against eosinophils. If the patient has eosinophil, the higher the eosinophil, the higher is the severity of the inflammation and severity of the disease.
Thank you, sir. So you had covered all the management options as well as the doses of ICS and all. In reference with that, sir, there is one question: how to titrate the dosage of inhalational controller medications?
Again, it's a bit arbitrary, but as per the GINA guidelines, there are guidelines. You look into the symptoms. If the symptoms are intermittent and not coming, say, 2 to 3 days a week, or maybe 2 to 3 days a month, then you can use low dose inhaled corticosteroid, the 200 to 400 microgram. But now we say you should always combine them with long-acting beta-2 agonist. Previously, it used to be only give inhaled corticosteroids and SOS, short-acting beta-2 agonist.
Okay.
But now we say you should give it in combination. Even as a reliever, you should not give short-acting beta-2 agonist alone. Because if you give beta-2 agonist alone, because they are very effective in relieving bronchospasm, the patient feels much better. So there is a tendency on the part of the patient to overuse short-acting beta-2 agonist and not take the anti-inflammatory agent. So it is. So now we feel that it is much better to integrate both the treatment together. That means you combined inhaled corticosteroid and long-acting beta-2 agonist to treat both inflammation and bronchodilation. And the dose is low dose when the symptoms are intermittent or not lasting for 2 to 3 days a week. But once the symptoms become almost daily, then you can use intermediate doses, say 400 to 800 microgram of budesonide. What you can use in that situation. or higher doses. And if the patient's symptoms are, much more severe, they are occurring during the daytime, during the nighttime, patient is getting frequent attacks, and if the lung function shows moderate to severe airflow obstruction, so in such situation you use a higher dose. But this selection of the initial selection of the dose is dependent upon these symptoms. This may actually not indicate the true severity of the disease, because the severity of disease would depend upon the response to therapy. So you can choose that, as you asked, the initial titration. So the initial titration can be based on the severity of symptom with which the patient has come. And once you start the treatment, then you may see the patients who are going to respond very well. Their symptoms will disappear, their lung functions will improve, their exercise tolerance will improve. In that case, then you can step down, as I mentioned, their dose gradually till their inflammation remains controlled. And to check for the control of inflammation, there are a number of methods which I mentioned. Either you look into you use asthma control test, the asthma control test questionnaire. When their score is more than 21, it indicates a good control. Or you can use peak flow meter. And now we are also using exhaled nitric oxide, exhaled breath nitric oxide. That also gives you some idea about the control of the asthma. So that's how you have to do it. So this has the whole overall asthma management and control may take 3 to 6 months of treatment, where you are calling your patient at a monthly interval and you are evaluating the patient, and then gradually you readjust their doses for this thing. Because a patient who comes with severe inflammation of the airways, where the airways are inflamed, their epithelium is completely ulcerated, eroded. So once you start anti-inflammatory drugs, it takes weeks to months for this inflammation to completely resolve. So first there is a structural recovery. So there is the inflammation resolves, there is a re-epithelialization, and then there is a functional recovery. That means hyper-reactivity of the airway may also take. So the overall, control of the disease occurs something between 3 to 6 months of treatment. And once you achieve that, and then you try to step up and step down the treatment and find the dose on which you keep that control on long-term basis.
Thank you, sir. So there are multiple questions, sir, but because of time constraints, we'll take the last 2 questions. Yeah. The next question is the role of Montelukast plus levocetirizine combination.
See, Montelukast, when you are talking about asthma, there is the Montelukast role is as an add-on therapy. As I mentioned to you, the inflammation in asthma is very heterogeneous. It is diverse. It involves basophils. It involves Th2 cells. It involves eosinophils. And these Montelukast have no role against eosinophilic inflammation. So it is only against leukotrienes which are released by basophils for this. So its role is very focused and limited. So when you are using Montelukast for treatment of asthma, you will use it only after you have given inhaled corticosteroid and the patient response has not been satisfactory. Then you give add-on Montelukast. But when patient has associated comorbidities like allergic rhinitis, or patient is a smoker, then Montelukast, levocetirizine, can be added early. So they become much more important, because then you are using or exercise-induced asthma is there, where basophils are ruptured, basically. So exercise-induced asthma, allergic rhinitis, asthma in smokers. So in this situation, along with inhaled corticosteroid, I think, or asthma following a viral infection, particularly, the post-COVID asthma, post-COVID cough, and a lot of mucoid secretions, as you can see here. In that situation, and the patient also have running nose and viral rhinitis, viral triggered asthma, then I think Montelukast and levocetirizine combination is a useful drug in such situation.
Thank you, sir. So there is one query. Is there any role of antibiotics in asthma?
Yeah, there is very limited role of antibiotic. As I again, I will again refer to that slide of inflammation, where I said that the asthma can be caused by diverse triggers. Where on the left side I showed you Th2 pathways, where there are pollens are there, allergens are there, house dust mite is there, and on the right side, we talked about pollutants, we talked about microbes, we talked about viral infections, all those things. So those pathways are not allergic pathways, but they are through different Th17 pathways where you have neutrophilic asthma. So in patients, with that subtype, where the majority of the asthma is neutrophilic, basically, and not you're not finding eosinophils, you're not finding increase in IgE levels. So those patients, I think, where microbes may be their atypical microorganism may be responsible for the causation of asthma. The role of antibiotic like azithromycins and those things, they are used as antibiotic or as a immunomodulator or anti-inflammatory role, the multiple role. So those are the situation where I think antibiotics have been tried.
Thank you, sir. So thanks for addressing all the queries, sir, and also taking us in details. So just for the audience, before I conclude, we will be sharing a feedback form, which we require supporting the feedback. And with that, I conclude the session. And on behalf of Sun Pharma team, I would like to thank our expert for today, Dr. Jagdish Chandra Suri, sir, for sharing their enormous experience and providing valuable practical experience, which would help take better and effective asthma patient care. At the end, I would also like to thank our entire team involved in this program, including the backend team, for their all kind support in making this event possible. I would also like to thank Mr. Lakshman. And to all the audience, thank you once again for joining, and stay safe. Again, a repeater, there will be a feedback form. I would request all the audience to share your feedbacks on this webinar, which will help us improve this work. Thank you, sir. Thanks for sharing your experience.
Okay. Thank you. Thank you once again for this invitation.
Thank you, sir.